The goals for this talk are to recognize infection, work it up, and manage it after a workup. Septic arthritis has a variable epidemiology. Overall, maybe about 8 cases per 100,000 children per year. Incidence is higher in sub-Saharan Africa and lower in European countries. It's mostly in young children less than 3 years old. The hip and the knee represent the bulk of these cases, about 35% each. The mechanism can be hematogenous spread in a child that has an ear infection, a genitourinary infection, or a gastrointestinal infection. It can be through direct inoculation, or it can be through adjacent osteomyelitis. Adjacent osteomyelitis would be more common in the joints that have intra-articular metaphyses, namely the proximal humerus, the proximal radius, the proximal femur, and the distal tibia. Consequences of untreated septic arthritis are cartilage destruction through the matrix metalloproteases, actions on the cartilage, avascular necrosis due to pressure injury from increased intracapsular pressure in the setting of septic effusion, and then the systemic consequences of sepsis if not treated. Microbiology of septic arthritis varies by age. In very young children, group B strep and gram-negative bacilli have a higher prevalence, perhaps because of the passage through the birth canal, but Staph aureus is also present. Age 3 years to 5 months, Staph aureus is traditionally thought to be the most common. However, Kingella is also becoming more common recently, and it doesn't necessarily show up on standard culture medium, so a rapid PCR can be helpful to identify that. Age 5 to 12, Staph aureus is most common, and then in older children have to watch out for Neisseria gonorrhoeae. In children who are not immunized, you have to watch out for Haemophilus influenza type B. Children with sickle cell are at a higher risk of salmonella. However, Staph aureus is still the most prevalent. For immune-compromised children, fungus or less virulent microbes can also be causative. And then adolescents, again, with the gonorrhea, the unique aspect of gonorrhea is that it can often be treated just with antibiotics alone, not with surgical debridement. The differential diagnosis for septic arthritis is broad, ranging from trauma, sickle cell crisis, SCFE, adjacent things such as lumbar discitis or testicular torsion, Lyme disease, inflammatory arthritis, malignancies. However, most commonly, we are trying to make a decision between transient synovitis and a septic arthritis. Take a history, ask about history of trauma, duration of symptoms, recent illness, a vaccination history, travel history, sick contacts, or any recent or current antibiotics that may be masking symptoms or interfere with culture results. Go into the room and look at the child. Do they appear ill? If they're playing on their iPad and wriggling around, it's probably less likely to have a septic hip and more likely a transient synovitis, whereas the child with the septic hip may be kind of lying still and in some distress. Their refusal to bear weight. If a child has a septic hip, they're much less likely to bear weight. They probably won't be bearing weight, whereas the children with transient synovitis certainly can weight bear on occasion. And it's important to check this yourself, not just rely on reports. Pain with passive range of motion is typically thought to be with short arc motion with septic arthritis, whereas in transient synovitis, it's more at the terminal ends of the range of motion. On the right is the characteristic erythema migrans rash of Lyme disease, which is kind of a unique finding because typically in septic arthritis of the hip, there will not be erythema or swelling visible as it's a deep joint. Oftentimes you can see the leg in a flexed, externally rotated abducted position, which maximizes the capsular volume to accommodate the effusion. Again, transient synovitis is a reactive condition of the synovium. It's the most common cause of acute atraumatic hip pain in children ages 3 to 8. 5% of the time it's bilateral, but it's typically unilateral. It often follows viral illness, and it's a diagnosis of exclusion. How do you distinguish it? Again, children with septic arthritis look sick. Kids with transient synovitis typically look not that bad. The fever would be much higher in septic arthritis, over 38.6, 101.5 for us here in America. Septic arthritis, children typically resist all motion, or in transient synovitis, just the end range of motion. And then transient synovitis also often has a history of a preceding viral illness. Workup is with labs, CBC with differential, CRP, ESR, blood cultures, plus or minus a Lyme titer if there's a history or geographic location that is suggestive of a risk of Lyme infection, Lyme disease or tick exposure. We can use the Coker criteria and the modified Coker criteria, combining the white blood cell count, ESR, the temperature, and the children's ability to bear weight or not to predict whether or not they have a septic arthritis. A child with all 5 of the modified Coker criteria is quite likely to have a septic hip, whereas a child with 1 is quite unlikely. If you have a child who's got probably at least more than 1, you consider an ultrasound to evaluate for a hip effusion. You get some more imaging. So you want to order the imaging simultaneously to the labs to avoid delay, an AP and a frog lateral of the pelvis, an ultrasound. Bone scans are not particularly helpful unless you're looking for a multifocal infection, like perhaps in a neonate, and then MRI can sometimes be useful. AP and frog view of the hip helps you rule out a fracture or a slip capital femoral epiphysis or malignancy. Look for joint space narrowing. You can see bony involvements like osteomyelitis as well. Ultrasound is probably the most helpful. You want to get both sides for comparison because there can be some physiologic joint fluid. Both transient synovitis and septic arthritis can have effusion. However, if you don't have effusion, it's very difficult to have a septic arthritis. You can also see for bony involvement that might demonstrate osteomyelitis on ultrasound. And ultrasound, like I mentioned, is not very good to differentiate septic arthritis from transient synovitis because they both have an effusion. MRI is especially helpful to determine if there's adjacent osteomyelitis or with and without gadolinium contrast, but do not delay treatment. If your institution is going to delay you for 2 days to get an MRI and the child needs surgery, just do it. A recent paper coming out suggested that pain greater than 4 days is highly predictive concomitant arthritis in children with septic arthritis. So perhaps you have a child that you're pretty sure has septic arthritis, but they've had a week of pain prior. It'd likely be helpful to get an MRI, again with the caveat if it doesn't delay care, to help determine if there's any adjuvant procedures needed to do rather than just an IND of the hip. On this image, you can see a big effusion. MRI can also be helpful to show you when it's something besides a septic hip. It's a recent case. Patient had 3 out of 5 a modified Coker, but they had an excellent passive range of motion in their hip. On the left, you can see there's no hip effusion. On the right, you can see a large psoas abscess. So if the physical exam doesn't make sense with the labs, an MRI can be very helpful to try to tie it together. On an aspiration, you want to get look at the white blood cell count plus differential, gram stains, and culture sensitivity. It can be done with IR or ortho, whatever your institutional preference is. Looking for greater than 50,000 white cells to indicate a septic arthritis. The way I do an aspiration is I drape it out with blue towels on a radiolucent OR table, place a spinal needle just under the palpable adductor tendon with the hip extended and abducted. I aim at the ipsilateral nipple about 45 degrees from the table, and I confirm them in the joint with fluoro. If on aspiration the fluid is grossly purulent, I would just convert to drape it out for an open irrigation degradement, or you could wait for the cell count if it's more of a borderline case. For children with transient synovitis, the treatment is rest and activity restrictions, treatment with non-steroidal anti-inflammatories. They should improve within 48 to 72 hours, often sooner, perhaps if they're given IV Toradol, and the average course would be 10 days. But it's important to check in with them and make sure they're improving. If they're not improving, I need to kind of reopen your suspicion for septic arthritis. Treatment of septic arthritis is an operative IND. It's going to be done with the bikini incision or a short oblique incision about 2 centimeters distal to the ASIS. The intervals between the tensor fascia lata and the sartorius. Watch out for the lateral femoral cutaneous nerve. The deep intervals between the rectus femoris and the gluteus medius. You want to clear off the anterior capsule of the hip with a Cobb elevator, make a centimeter square capsulotomy, and you can put a drain in posteriorly to give you some window into what's happening under the skin after you've closed the wound. I typically don't close deep layers and just close the skin with the PDS and monocryl. If there's osteomyelitis, I'd consider femoral neck drilling. Typically protected weight bearing as tolerated if septic arthritis alone. If there's osteomyelitis, depending on the extent of it, that may modify the weight bearing. Antibiotics, you want to obtain culture both of the joint and the blood before starting antibiotics, unless the child is systemically unwell. You base your empiric treatment on epidemiology of your region. Tailor your antibiotics when the culture data returns, and you'll treat with IV antibiotics until the clinical picture improves, as seen by pain control or a reduction of CRP to less than 50% of the initial maximum. Neonates, immunocompromised children, patients with MRSA positive cultures or salmonella might require much longer treatment or longer IV treatment. If there's not significant improvement on antibiotics, consider an MRI or repeat aeration debridement. We want to avoid these complications like sepsis, chronic osteomyelitis, pathologic fracture, growth disturbance, femoral head destruction, contracture. Thank you.